Clin Haem Hematology Demystified.
Hi everyone, today's topic is group and screen, and this is one of those terms that you will definitely come across if you are working in medicine, no matter what specialty you are doing, and or you will be doing if you are a medical student. So let's try to simplify this and see what exactly this means in the context of pre-transfusion compatibility testing. And to highlight why this is important, there is a case of a 62-year-old female who was having a routine surgery, which was very low risk, but she came to significant harm because she was given the wrong blood group, which is blood group A, and she was blood group O. And in the future slides, I will try to briefly summarize why this happened. Now, what she ended up with was an acute hemolytic transfusion reaction, which led to organ failure. So that's why we have compatibility testing, which helps ensure that the right blood is transfused to the right patient. And this involves two main steps, which is group and screen and a cross match. But before we go into that, I think it's important to just briefly go through some basic details about blood groups. The first, for all of you who've grown out of medical school, you probably know this from medical school, right? And this expression is not, you're not unfamiliar with this at all if you are a doctor, but medical students will be surprised to know that how many things they are going to forget that they thought they would never forget. But anyhow, so here's a quick refresher on the important things about blood group systems. So the first thing about them is that there are actually quite a few of them, and there are a total of countless blood group systems, but there are some of them which are more clinically important. So when we say clinically important blood groups, we mean in the context of uh, causing clinically significant hemolytic transfusion reactions or hemolytic disease of the fetus and newborn. And two of these are most important, which are the ABO and the RH blood group. And as you might have heard, if some people are A positive, that means they have blood group A, and they are RH positive, as you will come to. So a bit more detail about these blood group systems. So this is about blood group sorry, this is about ABO system. So if a person is blood group A, they have naturally occurring antibodies against B antigen. And if somebody has blood group B, it means their blood cells have B antigens and their plasma has antibodies against antigens. Now, if they have blood group AB, they have both of these antigens on their blood cells. And since they have both of the antigens, they can't make antibodies against A or B antigens because your immunity is not supposed to make antibodies against your own antigens. In group O, they lack both A and B antigens, so that's why they have both A and B antibodies. In the ABO blood group system, these antibodies are naturally occurring, which means that they are actually present few months after birth. There are theories, to suggest that this might be because as we grow, our gut is colonized with some bacteria, and they share similar characteristics with these antigens. So our body tries to develop antibodies against them, and they remain throughout um, a person's life. So of course, if a person has blood group A antigen, they won't make antibodies against A, but they would make against B antigen and vice versa. These antibodies are IgM type, as you can see. These are pentamers. So these are IgM types of antibodies. As you might know, there are five types of antibodies, which we can come to another discussion. But IgM is the one that actually fixes complement, by which I mean it can directly activate complement proteins, which you probably do remember, and we will hopefully do a session on that as well. So what happened in our lady is that she was blood group O and she was given blood group A. So she was O, which means she has naturally occurring anti-A and anti-B antibodies. And when she was transfused the A blood group, the red cells in the donated blood had lots of A antigens on them. And these antibodies that were already present, waiting for, for an A antigen, found the chance, and they would bind to these antigens here on the donated blood, activate complement on the surface of the red cells, causing red cell lysis, which will release toxic hemoglobin, activate in the coagulation system, activate inflammation, and thus cause DIC, multi-organ failure, etc. That is why it is absolutely not acceptable to give anybody wrong blood group from the ABO system, because that has got life-threatening consequences. Now, I hope this is clear. And in contrast to that, we will move to RH blood group system. So the RH blood group system has got five different principal antigens, and D, E, E, so D, um, capital E, small e, capital C, small c. D antigen is the most important. So when somebody has RHD antigen, we say they are RHD positive. If you have then lack RHD antigen, we say they are RHD negative. RH antibodies are immune, like most other blood group system antibodies, unlike ABO blood group system, which means that they need exposure to RH antigen from somewhere, like a blood transfusion of an RH positive blood to an RH negative patient to stimulate them to make antibodies. And just to note that small lowercase d antigen doesn't exist, so either a person would have the capital D antigen or they would lack the D antigen, but they can have a capital E or a small e. So they are they are antigens in the opposite to each other, but there's nothing complementary to D. Now this is just another diagram to explain the same thing. So if you someone is RHD positive, this means on their red blood cells there are RH antigens, RHD antigens, and if they are RHD negative, their bloods will lack the RH antigen. And if we combine ABO and RH together, so a person who has blood group A RHD positive would have A antigens and RHD antigens on them. And similarly, if somebody is AB RHD positive, then they would have A antigen, B antigen, and RHD antigens on them. And of course, they are Rh negative. They do not have RHD antigen on there. So I hope this simplifies, but I'll go back to this again just to highlight that. So these blood group systems, there are quite a few of them, and they are, different blood group systems have got a person can have different types of those blood groups depending on whether a person has that particular molecule in a blood group system, a particular version of it, or if it's absent. For example, in ABO blood group system, we have got the option of having A, B, or both AB or nothing. So AB, 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 or O. And in RH, you have got the option of having an RHD or not having an RHD, or you have the option of having an E antigen, capital E or a small E antigen. But as I said, the clinically important ones are these two. And this is where we're going to move on. So with this background, we can know what we are doing in a group and screen. So a group, when we say a group and screen, it means group and screen. So the group means we see what the patient's ABO and RHD group type is. When we say screen, we check for a patient's plasma against any antibodies against any of the red cell antigens. Um, and I've highlighted to say non-ABO because if they are, because ABO antibodies are naturally occurring, as I've explained already. And the last step is a cross-match, which is checking for a reaction between patient's plasma and the potential donor cells that are going to be infused into them. Now, I will try to break down all three of them, starting with the group. So in the group specifically, I'll start with ABO group and try to explain how actually ABO group is done. ABO group is because it's so important, as I've explained, because of the naturally occurring antibodies that fix complement. We have two ways of doing it, and we do both of them in every patient. Um, so they are called forward group typing and reverse group typing. And basically, it's not too complicated. Basically, what it means is that in forward group, we will take a reagent that contains, that we know if it contains anti-A an antibody, or anti-B antibody, or anti-AB sorry, anti-A antibody or anti-B antibody, and we will react that to the patient's cell. So, for example, if a patient is group A, they will have group A antigens. So, when we add A anti-A, they will to that patient's blood sample, it will agglutinate and cause a reaction, and we will know, okay, the patient has got group A. Of course, they will have no reaction to this patient will have no reaction to adding anti-B antibody, which means, so if this patient was group B, if we added anti-A, this will not cause any agglutination, and it would show a negative or absent reaction. In the reverse group, as the name suggests, what we do is we actually use patient's plasma, which and then react it against red cells, this time of known antigen expression in the ABO system. So reagent for example, if we use reagent group A cells, so we know in a bottle that this blood is from a group A patient. We've already typed them. So what we will do is we will add patient's plasma, which contains antibodies to A or B or AB, and we'll see what happens. So for example, if the patient has got group B, if the patient is group B, they will have anti-A antibodies. And if you react them with group A antigen, it will cause agglutination and vice versa. So that's how forward and reverse group work. Forward group, we use an antibody, a known antibody like anti-A or anti-B. In the reverse group, we use a known reagent red cell and expose them to patient's plasma. That's forward and reverse grouping for ABO. For RHD is simple. We have known monoclonal anti-D antibodies in the lab, and what we do is we react them against the patient's cell to see if there's a reaction or not. If there is a reaction, as in this example, then this means that the patient has RHD positive blood group. This is actually exactly how they do it in the lab. So I've just shown you how it looks like. So this is a gel card, and this is the key. So a positive reaction would look like this, a blood clot on the top, and the negative reaction, the blood will just settle at the bottom. So in this, let's try to see what the forward ABO group looks like. So when in this, there is a reaction to A anti-A antibody, but there's no reaction to anti-B antibody. So this suggests that when they added anti-A antibody to patient's red cells, there was a reaction, which suggests patient has got A antigens, but doesn't have B antigen. So it looks like from the forward ABO group that this patient might be blood group A. And then we will do the reverse blood group again, and it confirms that there are the patient plasma reaction shows a reaction with B cells, suggesting there are anti-B antibodies present as expected. So B cell reaction with B cells is positive, with A cells is negative, and that's consistent with the forward group. So that means that the patient has got blood group A. Now for RHD, you look at this section here, and it shows that the patient had, when they added anti-D to patient's red cells, there was a reaction, which means the patient has RHD antigen, which means they are RHD positive. So this patient's blood group is A positive. Okay. Now going on to that was group. So in group, after group, we do screen. Screen means screening, as the name suggests, for any antibodies against red cell antigens that a patient might have in their plasma. Again, I mentioned non-ABO because, as you know, everyone would have naturally occurring antibodies to, ABO system unless, of course, they are AB, blood group AB. Um, so that's why what we do is in this screen, we use two or three. cells who have known expression of the most common and most important antigens amongst them. And all of these groups, all of these blood cells that we use for screening are group O because we don't want interference with ABO antigens. So group O cells won't have any AB antigens. That's why the screening cells are group O cells, which have known expression of most important antigens from other blood group systems among them. So what we're doing here is, as we are going to take patients' plasma and react them against these known reagent cells. If this reaction is positive with either of two or three cells, most hospitals would use three-cell screen. Then we say that the screen is positive for some antibody. If it's negative, we don't, it means that the screen is negative, which means that the patient doesn't most likely have any antibodies to any non-ABO clinically significant antigens that these three-cell reagent cells have on them. But if it's positive, we need to see which antibody it is, and that's done by antibody identification test, which is basically doing the same thing, taking patients' plasma, and this time testing them with, instead of three red cell red cells, reagent red cells, we would test them against 10 or 12 of reagent red cells who have again known, we do know again for them as well that which antigen they express on their cell surface. So this will help us identify which antibody it exactly is. And this is the literally the chart that they will use in laboratory to do this. So the top one shows the screening cells. So as you can see, all of these cells, so 1, 2, and 3, all of these cells are group O cells. The first cell has these antigen expressions. So for example, they are positive for capital C, capital D, and capital E is negative, and small c is negative, and small e is positive. So this is for the Rh system, and these are some other antigens. Similarly, this is for the cell number 2 in the screen, and this is cell number 3. And as you can see, they differ in their antigen expression. But with this, if one of them or two of them are positive or three of them are positive, you cannot identify which antibody it exactly is. That's why we use 10 to 12 cells instead of three, which share those antigens in a bit more broad way. So we know, and then once we know what the pattern is of reaction to all of these red cells, we can try to how um, work out which antigen this patient's plasma is reacting to. And this is a lecture on its own. So we will try to do that with some case examples in a different video to see how exactly we play this game to see which antibody it is, if it's been identified in the screen, to see how it is in the panel cells. Okay, so that's screen as well. Okay, so it was stuck. So what's the outcome of a group and screen? After we have done group and screen, we know what the patient's ABO type is, we know what their RH type is, and we also know what if they have any antibody to any antigen. All of this is to ensure compatibility so that we can choose the right donor cells. So what we mean is that we choose those cells those red cells for a patient that are of the correct ABO and RH type as matched with the patient. And they are also, those donor red cells are negative for any antibody that we might identify in the screen. Because, of course, if the patient has an antibody in their blood, then that can potentially react to the donor antigens if they have those corresponding antigen, and that would cause a hemolytic transfusion reaction potentially. Now, this is ensured in a final step called crossmatch, and I will share that in the next slide. And this is how you decide which blood group is suitable for which patient. And it's just the same. It depends on which antibodies they have. And as you might know, group O has no antigens, but they have both A and B antibodies. You cannot give them anything other than O, because if you try to give them A or B, they will have a reaction like with our patient in the beginning. She was group O and she was given um, group A blood. So cross-matching, as the name suggests, is where we take patient's plasma and we mix with the donor cells. So the donor cells have been selected for patient's ABO type, RH type, and also a negative for any antibodies that they might have. But just to be on, this is an extra step taken to make sure, our testing is okay and the patient doesn't get a reaction. So if the patient's plasma is mixed with donor cells to see if a reaction, agglutination or hemolysis occurs or not. If there's no reaction, RBC units are compatible. There's no risk of acute hemolysis, and the baby Yoda is quite happy there. But if there's a reaction, these RBC units are incompatible. There's a risk of acute hemolysis. Baby Yoda is unhappy because he has to do the group and save and screen and cross-matching again and find at the blood cells and see why the cross-match has come back positive. But hopefully we have prevented an actual transfusion reaction, because we have prevented prevented the patient from having a wrong blood type. So that is all, and this is just a summary slide. So when we say group and screen, what we mean is in group, we mean that we are trying to check what the patient's ABO blood group and RHD blood group are. In the screen, we are checking for which antibodies they have, if any, to any of the clinically significant red cell antigens. And the cross match, we try to see if the selected potential donor cells, if they are compatible with patient's plasma. And just to mention that in many circumstances these days, we actually do not need to do a physical serological cross match for uncomplicated, straightforward cases where there's no antibody and there's no suspicion of any abnormality in the group and save and cross match or transfusion history, etc. Many laboratories will now do what's called an electronic issue, and there is a strict criteria for that, which is available on the BSH guidelines, and then we will hopefully cover that one day as well. Yeah, so that is all for today. Let me know any questions or any clarifications if you need in the comments below. Thank you.
Thank you for watching. Stay tuned for more.